Thank you. Okay. Hello, good morning. So today, as Jeff said, I'm going to speak a little bit about clonality and immunoglobulin somatic hypermutations in CLL. So this is an overview, so it'll suit some people that are beginners in this field, and then we'll move on and we'll talk about interpretations and quality control programs. Okay, so this is a very nice picture. It's not actually where I work because it hasn't been built yet. I'm afraid I'm working in a building site at the moment because we're putting in the National Children's Hospital, and the National Maternity Hospital is actually being joined to our own hospital. So where I actually work is in the Cancer Molecular Diagnostics Department in St. James's Hospital. And we offer a nationally accredited molecular hematology and solid tumour service for the Republic of Ireland. So our experience in clonality, I myself have been doing it for about 20 years. We analyse about 800 cases annually of clonality, more T's than B's, and approximately 120 cases of somatic hypermutations. So most of the samples I see for clonality, a lot of them will be paraffin-embedded material, but we also look at a variety of other samples that I've listed there for you. So some of the EQA schemes that we're involved in, we're one of the European certified centres with Euroclonality. We also take part in the UK NetQuas. We're also a European certified centre with the European Research Initiative in CLL for IGH somatic hypermutations. So we go on to clonality analysis. We all know why we do it. We're looking for a clonal population, and most of the lymphomas we're looking at don't have a specific genetic marker. So for B cells, we're looking at immunoglobulin gene rearrangements, and for T, TCR gene rearrangements, with the premise that all the cells of the malignancy come from a common clonal origin. So because we have a very, very vast array of rearrangement potential in our immunoglobulins and our T-cell receptor genes, we can create up to 2 by 10 to the 12 different immunoglobulin molecules. So when you're looking for a clonal population and you're bringing it up, the chance of something else having exactly the same clonal population would be very, very rare. There is a lot of the recombination between the segments themselves, which are very numerous. You have about 48 V segments, about 23 Ds, 6 Js. Then you have a lot of somatic hypermutation later on, but even before that, you've N-terminal diversity, where these segments join, and the action of dinucleotide transferase there will basically delete some nucleotides and add some new ones. And those are the area that our previous speakers already talked about, that where you'd be creating your allelic-specific oligoprimers if you're doing MRD. So the hierarchy of arrangements, how they actually work, and this is important if you're looking or trying to see whether you're dealing with a more immature or a more mature lymphoma or lymphoproliferative disorder. So in B-cell clonality, the diversity to the joining segments of the immunoglobulin, heavy chain join first, followed by joining of the V region. So why do we look at 3 different spots in that same heavy chain locus? We're looking at framework 1, 2, and 3, because a lot of the, as I said, lymphomas are highly mutated, and a lot of the times you're going to have mutations in some of those framework regions, obviously that won't amplify with the primers. So you also can use the kappa gene rearrangements there. There's a 2-tube assay for this. And I suppose one of the reasons we're talking about, well, this methodology is the one that we use in the lab, the fluorescent PCR-based technology. People do use in-house methods, but of course, next generation sequencing, of course, will be coming on board. And as more people get used to that, technology price goes down and more experience is gained in it, I'm sure it will take over and people will be batching lots of different libraries together on instruments. So in T-cell clonality, delta rearranges first, followed by gamma, then followed by TCR beta. And when alpha rearranges, delta is in the middle, so delta will delete. So what do? The analysis flow. Well, what's recommended is that you look at the IGHV 1, 2 and 3 plus the kappa, V2J and kappa deleting elements. If you don't get conclusive results in that, and there's still clinical suspicion, you go to a second round. And what you do is you look at the early markers of the immunoglobulin heavy chain, and you also look at lambda. Lambda is a really lovely one to look at. It's very sensitive, but it's got a high background, so you really do need people that are experienced in actually looking at these. Okay, and for T cells, TCR beta, both complete V2J and incomplete D2J, followed by TCR gamma. And only use deltas for suspect gamma delta rearrangements. Now, this is very important. We do use it in our first screen, but we're very, very used to dealing with it. What happens with delta is, because there's very few delta cells around, you will get concurrent amplification of background delta cells. So you have to be very aware that some peaks will obviously be clonal rearrangement that you see in other assays, but when you see peaks in a delta, when you're doing a straight off first screen, just be very aware that they could be background cells. Okay, so what methodologies do we use? So going back to 2003, this is when some of the biomed primers, and they were involved in standardizing protocols and primer methodologies. Now, things have moved on from them, but up to date, I know that most people still use multiplex PCR assays. Either you look at them fluorescently or you look at them at heteroduplex. However, now about 10% of the centres that I'm aware of are carrying out and starting to use NGS to look at clonality. So there are some technical and analytical considerations when you're looking at these. So some assays have different sensitivity than others. If you want to be interpreting them correctly as to whether you're looking at biclonal or biallelic rearrangements, you really have to have a knowledge about how many rearrangements you can get on each locus. You can get up to 4 rearrangements on the TCR beta rearrangements, and you can get up to 4 in the kappa rearrangements, and they can still be indicative of a monoclonal population. So if you're going to go down that route of giving additional information on whether it's clonal or not, be sure that you have the information there as to how many rearrangements you can have in each locus. Some assays will give a peak, where a peak does not mean a clonal product. Kappa is one of the most famous ones for doing that. It gives 148 base pair peak. That's actually the most common rearrangement that you'll find in the kappas. Okay, and the reason you see it is because there's a very actually restricted repertoire of V2J regions in kappa, so it'll come up. And I've got slides later on that are going to show you the difference between them. Okay, and very important not to overcall. Okay, especially in some of the assays that will give you slight little peaks, but that's all to do with experience. Okay. Some of the things we're finding now more and more, when I first started, we used to get lovely excision biopsies. But of course, as the healthcare system goes on, less time in day wards, we seem to be getting a lot of core biopsies now sent to us. And by the time they finished immunohistochemistry, there's really very little left, in these. So that's definitely very challenging. Okay, the other thing is always report in conjunction with the clinical immunophenotype and histopath results. We have noticed we've been sent some things. First of all, we get nothing, in the sample, hardly any polyclonal even. And you'll find that actually it's been sent to us by maybe a junior member of staff that actually sent us a patient that had been treated. You also have, when you look at the clinical information, you might bring up a beautiful clonal profile, and you're actually reading the information, you find they actually have active EBV infection. So that's a bit useless if you're looking for a lymphoproliferative disorder when you see that, because you don't know whether it's one or the other. Okay. Elderly patients, do watch out. Their immune system repertoire is getting less because of immunosenescence, so you can bring up peaks there. Also, I work in the National Adult Transplant Unit, and sometimes we would get queries as to, is this a query post-transplant lymphoproliferative disorder? And you look at it, and what you see is these oligoclonal things coming up. And basically, that's just because the actual repertoires of the B and T cells haven't fully completed yet after the transplant. And then what I find very helpful is if people will actually give you a percentage of the tumour infiltrate in the sample. And if it's not diffuse, if it's only in a small part, it's actually really nice for them to mark out. So there are guidelines for interpreting and reporting here. So I've put up the papers that you can look at, and these have been updated as well. And the interpretations, as I said, you can have clonal, polyclonal, you can have no template, oligoclonal, a dominant clone in a polyclonal background. Obviously, if you use something like NGS, something like a dominant clone, an oligoclonal background, is going to be very obvious. Sometimes, depending on where it sits on your Gaussian spread, it's more obvious if it's to the side, obviously, than if it's in the middle. So as I said, when you go to NGS, this actually is where it can really, really help detect those, because they're difficult ones. Okay, so just to show you what these Gaussian spreads look like. So this is the immunoglobulin heavy chain, and here are the Gaussian spreads for FR1, FR2, FR3. This is that peak I told you about in kappa A, and here are the other Gaussian spreads. So this is just, at the moment, that's the heavy chain. So here you see your clonal FR1, FR2, FR3. Now, this is the kappa here. That's at the exact same point as the polyclonal. But what you'll notice in the polyclonal, just a hint, we always call it, it's got two shoulders at the side, low shoulders. Okay, whereas you see the clonal one, first of all, the shoulders are gone, and you also see what's known as a ski slope artifact if you've got a big clone, because that's to do with flashing of the detectors when it's coming down through the capillary with the huge amount of fluorescence that's on it. Okay, and then your quality control size standard at the bottom to see how good your DNA actually is. Is it good to have 200, 300, 400? Obviously, it's best. Now, if you've got only 200, obviously you're not going to bring up some of those bigger markers. Okay, so what I say to people that have degraded DNA is maybe, tend to stay towards the smaller markers. So what Clonality is really good for, and we get a lot of this, is when patients come in, diagnosed, if they come back with a relapse, or if we're looking at other areas. So this is a case of a patient. We had a spate of them about 7 years ago. There was new leather couches being bought, and we had a load of people coming in with rashes on the back of their thighs. There was actually a new antifungal agent was sprayed on them, and actually loads of people had allergic reactions. So this man went to his GP, who referred him in for a biopsy to the hospital. There was a biopsy taken, and the dermatopathologist noticed that although it looked like an inflammatory rash, photographs by dermatology, when they actually looked at the distribution and the location of the lymphocytes, okay, she was querying, is this some type of cutaneous T-cell lymphoma? So they sent us down the skin biopsy, and you can see here, this is the first biopsy we received here. So on the T cells, you can see we brought up, the TCR beta mature rearrangement plus the two immature D2Js. And then we brought up the gammas as well. So once those findings went back, this man was brought in for a full clinical workup. Now, nothing had been noticed bar the skin when he went to his GP, because obviously they weren't thinking immediately lymphoma. So on full clinical workup, they noticed an enlarged groin node, and they also drew a bone marrow aspirate. And I think what you can see quite nicely here, this is like, if it's a fingerprint of the lymphoma that this man has. So it's very, very nice to be able to see that. And when you're doing it this way and you report it, you can say that you found similar clonal profiles elsewhere. Of course, if you've got NGS, you're lucky because you can say they're identical because you actually can see the sequence. Okay. This was a challenging case that was sent to me. It was a CSF, referred to us by our flow lab. They could demonstrate a majority of B cells, mature B cells, but they couldn't demonstrate monoclonality. So this is the primary screen here. We looked at FR1, 2, 3, kappa A, kappa B. And actually, I think we did lambda straight off on that as well. And basically, you can see, not only do you not see clonal, you barely see any polyclonal at all, which would be in keeping with the fact that they have 95% of the population. So you're thinking of, well, if you see something like that and you're not seeing clonal or polyclonal, there's something else going on that you're not catching. So you use your secondary screens, which are the D2Js, because we'd already used lambda in the primary screen in this. And you can see beautifully it comes up. Now, there are very few lymphomas that you will find that you can only catch with a D2J. You will usually find they're the early leukemics that you will see, but primary central nervous system lymphoma is quite a rare disorder. Okay, so by looking at this, by looking at the mature B cell markers, actually in the patient you knew it was mature, but the fact that you're bringing up nothing would lead you to conclude that, one, they're using rearrangements that don't come up. These are very rare that you have these, and not coming up in all the assays because there's complementarity between all the assays, or two, that it's very highly mutated in all the primer sites, which is usual for heavy chains, not so usual on the light chains, or a combination of those two. But anyway, we could bring this up at diagnosis, and all subsequent samples then, by using the same amount of DNA, looking at it, was like a semi-quantitative. You could see it going down as the patient was being treated. Okay, so it's just something to think about. If you get nothing, when you really think there's something there and there's other evidence that there might be something there, do investigate further. This was another case we were sent by our immunophenotyping lab. And again, we got nearly nothing. They said there was a majority T cell population. Of course, T is much harder to find clonality on these. So sent it to us and asked us to have a look at it. So we looked at it and we could find nothing. Okay, but when we went back, we signed these out in multidisciplinary MDTs. We could find out that this lymphoma actually was expressing CD1A, CD2, so it was actually a pro-T. Okay, rearrangements haven't even started at that point. Okay, so this is why you need to look, if samples do come in and just say T cell clonality and you go and report them as negative, just be aware without that other documentation, you can actually, give out a report that's not actually 100% accurate. It's negative, but it's negative for a reason, So some of the training and QC schemes that I would recommend, your clonality through the ELSHO, do plenty of symposiums and workshops, and I actually put up the next one for you there in Nijmegen. It's a 3-day workshop. Your clonality will send out 10 samples annually, and they'll actually send out 5 samples, and they will send out 5 interpretive gene scans to see, because that's, I think, one to show that you can actually do the assay from start to finish on the sample, and the other one, interpretation is key. So that's the way they're doing it at the moment. Obviously, when NGS takes off, they're going to have to think about sending you FASTQ files and things to look at, because, as I said, that is happening at the moment. But the only EQA schemes out there at the moment, they don't have capacity. They don't have, not capacity, excuse me. They don't use the NGS data. So changing focus now a little bit, we're still, of course, looking at the heavy chain of the immunoglobulin molecule here, and we're looking at somatic mutations. The 2 previous speakers have already shown that CLL varies from an indolent to a very aggressive disease course, and it can also change a Richter transformation to either diffuse large B-cell lymphoma or less frequently Hodgkin's lymphoma. So way back in 1999, it was Terry Hamlin's lab that showed this, that if you have a mutated IGHV region in a CLL, that you have a more favourable outcome. So, and Zadie Davis, the lady that wrote this paper with him, she is the one that runs the Bournemouth EQA for this as well. So it still holds up today in the CLL follow-up studies with FCR and FC that, again, mutated always do better. Okay. So here are some recommendations that you will find in the European Research CLL website that you can have a look at. And as I said, these will have to be updated again when NGS comes in. So basically, just to go through some of the methodologies, you can either use, you bring up your actual immunoglobulin, you PCR it up. You can sequence it in both directions, or you can do this by NGS. Now, that's the first part. It's all about interpretation of the data. Some of the NGS kits that are out there actually have software inbuilt. Okay, so if you have that, you're very lucky. Otherwise, you have to go and use a few other databases. And if you have a nice bioinformatician, it's great. He can pull your FASTQ files and actually do it all by a click of a button. We only got one this year, and it's been transformative what they can actually do to make your life better. So basically, you get your sequence and you put it into here, the IMGT website, and you come up with various productive rearrangements, the various usage of the genes, and what you actually report. You report down here all the usage, the percentage, mutation, whether it's mutated, unmutated, borderline. Now, a few of the other things you have to look at. Okay, in the FR4 region, you have to look at, there should be a cysteine at amino acid position 104, a tryptophan at 118, and they're usually followed by a GXG motif. Now, that's actually usually a GQG motif. So, and here I've just, when you put it into that IMGT website, it gives you all this data. So look down and make sure the C is there at 104, the W at 108, followed by a GQG. Okay, some troubleshooting. No rearrangement on repeat PCR. What I usually find is that's a reg that sent me a sample that's been treated. Okay, so that's why you don't get it. So sometimes rather than trying to go around and using other primers or whatever, you know, pick up the phone, like in that case, because as I said, that's what it usually is. What we did find, and one of our EQA samples showed this, that the multiplex kits did not amplify one of the samples that was sent to us on EQA. Okay, and most of the centres could not bring this up. So we have backups of, we have all the individual forward and reverse primers. We have reverse J's. We have the constant region primers that Mark was talking about, the IgA, IgG, IgM. Now, just let me tell you first off, it's rare that this happens. But if you're trying to find out, you need to have these other primers. But anyway, it turns out that some of the rearrangements that use V5, for some reason, do not come up in a multiplex. But if you use V5 or L5 on their own with the reverse primers, they do come up. Okay, so that's just something to note. Single unproductive rearrangement, usually very rare, you know. And what I usually find, it's usually something to do with your data editing. Your junctions, as I said, check those. If you've got a problem, Eric, just like Clonality do, they have online services where you can send them. For Eric, you send them the whole sequence and you write what's the problem, and they'll have their experts look at it. Clonality, you can send them all your files for your clonal profiles or whatever you're getting out of them. They have that facility available to them too. Okay, so that GXG motif, that's usually GQG, as I said, doesn't happen if you're using a J2 or a J6 where you'll get a GRG or a GKG. Now, sometimes you'll get GLG and stuff like that, but if it's productive and everything, you're fine. So again, the reporting, you have to make it very clear if this is mutated or unmutated, and you give them the percentage, and now you give them the usage of the genes. We tell them we identify what they are and stuff like that. Now, that doesn't mean much. The clinicians say to me, they just look at mutated and unmutated. And then one of the other things that we do is we look for stereotype subsets. So 30% of CLLs fall into stereotype subsets. These are ones that the commonality between the sequences of either the VDJ and the CDR3 regions are very common. And what they found is within these groups, they tend to clinically respond the same way. So you can find that if you go into this BAT Inspire. And I'm just, because people sometimes have said they weren't aware of it, I just have a couple of slides on this to finish it off. So the BAT Inspire here, you put in your FASTQ file, and the website is there. Okay, if you go onto the ERIC CLL website, they actually will have services, a button on services, and you can click that, and it'll have subset stereotyping tool, and that's where you'll get that. Okay, I think I showed it there, services with the arrow. Right, so you just put your sequence in there. Remember to start with a greater than sign and the name, or else it won't work. Assign to subsets, and what happens here is this particular sample got assigned into a CLL subset 8. So you just click here, CLL subset 8, and what comes up is that this is, if you look at on this side, it's a very aggressive disease. It's got a time to first treatment of 1.5 years. The highest risk of Richter's transformation among CLL subgroups. And if you look over here, especially when you're talking about Richter's, there is your notch mutation has been found in 30% of these cases. Okay? And trisomy 12 is there, which actually is not a bad prognostic factor, but it just goes to show that obviously if you've got the CLL 8 and the you can have it associated with the notch mutations, that this can change what if you just did your ordinary cytogenetic screen, you know. So there are certain subgroups, 1, 2, 3 and 8 that are very aggressive, and 4 then, that's the one that you find in your young patients. That is a very, very indolent one. So that's actually nice to know when you get a CLL patient in. We tend to do this sort of analysis usually before treatment. People are wanting to know about FCR, non-FCR treatment. But for a young patient as well, it's actually very nice to be able to tell them that they've got a very indolent disorder, because obviously they want to plan for their future. You know, so these are the various different papers I've put up for you here. And sorry, the one last thing about the subset, you'd only report on about the 4 of the major subset. They're the ones with the strongest data behind them. There are other subsets, but the data would be very limited in those groups. So I'd advise caution if you are going to report on them, say that it's a very limited data set. So here are some of the training and QC schemes that you can join. As I said, I mentioned ERIC already, and the online support you get, and the EQA schemes. As I said, we work with Zadie and the Bournemouth EQA, and ERIC sends you 10 samples every 3 years for certification renewal. And then these are my acknowledgements, the people that work with me. There'd be Emer and Fiona, and the MedLab assistants who do a great job in a national centre, and the amount of samples that we have coming in, and the variety of different extraction methods, and now all the new automation that we're introducing into the labs, especially for the extractions, but also for setting up the NGS libraries and everything else. So things have changed a lot in the last few years. So I just want to thank all of these people here. Thank you very much.